So can everybody see my screen and can everybody hear me?
Yes.
Yes, okay.
That's excellent. Thank you very much. So I'm going to make a start. I'll keep an eye on the participants as well. But today we're going to talk about a very, very important topic in really how we should be implementing lung ultrasound for management of neonatal respiratory distress syndrome in practice. It's going to be a short session. We're going to basically talk about this over about 45 minutes, and then the last 15 minutes we'll kind of take questions. But the intention from my perspective is to kind of give you a really good flavor of where and how we should be using lung ultrasound, but in particular the fallacies of using lung ultrasound scores. But before I start, what I'd like to do is start with a case. So I've got a baby X, who's delivered at about 30 weeks of gestation. The baby was born by normal vaginal delivery because of spontaneous onset of preterm labor. And really, the baby came out breathing with a good heart rate. It was vigorous, but had some subcostal intercostal recession. So we decided to CPAP the baby from birth. And once we started CPAP, the baby continued to recess. So the baby was transferred to the neonatal unit, has had placement on CPAP, and we're at this particular point on a PEEP of about 7. The baby's had golden hour, has had lines inserted, a UVC and a UAC, has had a screen, started some antibiotics, and started fluids. But a kind of assessment, just at 2 hours of age, shows that the baby has significant work of breathing. We don't have an X-ray at the moment, but our FiO2 is about 35%. And this is really our first gas, which was done about half an hour back. So I'm just curious. I'm curious to kind of have some discussion with everybody about what their approach would be at this particular point.
I think by clinical ground, the history and the clinical ground, should I start give servant? I want to do servant.
Okay. So Dr. Ashraf has very kindly agreed that, this baby sounds like a baby who might need surfactant. I would agree. I think from my perspective, that's really important. Shruti has brought up whether we should do less invasive surfactant administration. Amazing. Okay. Any other thoughts, folks?
Either by any investigation, we still have to prove that it is a RDS before we give surfactant.
Who is this? This is
Ravi here.
Ravi.
Hello.
Yeah, Ravi. Yeah. So
It
Dr.
may be pneumothorax, anything we are dealing with. So we need to
Fan-
go for any, that means ultrasound we have done.
I'll
Lung
show you the
ultrasound.
ultrasound images, but I think
But
yeah. Say, Ravi, carry on. You're saying something. Yeah.
yeah, before means it is, if it was less, like if we are using delivery room surfactant less than 28 weeks, then we can give without any. But 30 weeker we have to still prove that it is RDS. It definitely, it looks like the setup is RDS, but before either we need lung ultrasound or X-ray before giving surfactant. That's what my thinking is.
Okay, that's really helpful. So we've got a few views. Anybody have any other views? Strong opinions? Anybody? Okay, so I think what I would say is that let's stick with the clinical protocol. And the clinical protocol that we've always looked at is we are first going to examine our baby. I think the second thing from our perspective is we're going to look at the baby clinically, work of breathing. We're then going to assess the baby's history. Now, is there anything in the history that you want to know? Because people have kind of not asked me a few things that might be very important.
The mother antenatal steroid given?
Beautiful. That's really, really important. Thank you so much, Dr. Ashraf. So this is an unsteroided, very, very quick precipitate delivery in a baby who, from our perspective, is 30 weeks. Anybody want to know the baby's weight?
Yes.
So the baby is basically about 900 grams. So quite compromised IUGR. The mother also, from our perspective, had quite significant preeclampsia with high blood pressure that was compromising the baby's growth. Now, at this particular point, 30 weeks IUGR, no risk factors for sepsis. Certainly no preterm passage of meconium in this particular situation, but a baby who came out vigorous with normal cord gases, so not perinatally compromised, but with significant work of breathing, and is currently on quite high PEEP setting. So we're using a PEEP of 7. We have a high CO2 on the gas. Clinically, on examination, this baby has reduced right-sided air entry. And from our perspective, at this particular point, when we transluminate this baby, it's a little bit tricky because actually the baby is preterm, he's a little bit edematous, he's quite small, so he generally tends to transluminate a little bit everywhere. So who wants to do a lung ultrasound? Anybody want to do a lung ultrasound with that history before they give surfactant, or you happy to give surfactant?
Yes, we do ultrasound طبعا for sure.
Okay.
Ultrasound for Cervanta, sure.
Okay, great. So now we're going to show you the images. So I'm going to show you R1, R2. So the image at the top, you might hear me speaking. So anybody want to comment on that? So let me ask Shruti, can you hear me? Shruti, Dr. Bharadwaj?
Yes, I can hear you.
Lovely, Shruti. Would you like to comment on this image?
It looks like the A lines are, getting mirrored there.
Very good. So again, with the protocol,
Yeah,
R1,
that
bat wing sign visible?
wing sign visible. The pleural line seems to be a bit thickened.
Yep.
And it is continuous.
Very good. So it is continuous. Any evidence of subpleural consolidations?
No.
Okay, so we'll let Shruti have a look at it again. So what do you think, Shruti? Any subpleural consolidations?
Probably in this, on the right side of the image. Not sure.
Okay, not sure. Go with your gut. What do you think? Can you see anything that looks like a big snowflake sign or consolidation in this subpleural region? Yeah.
Yes, a little bit. Yes.
Okay, so that's a comet tail. This is a comet tail, this small comet tail here, but actually I can't see a B profile at all. I can see A lines all the way to the bottom in R1.
Yeah.
And this is a depth of 4 centimeters in a very small baby. Now, what do you see over here? So now you have a little bit of M mode.
Yeah.
There is lung sliding or not?
Very
I
good.
cannot see.
Very good. What do you think, Dr. Ashraf? You think there's lung sliding?
No, there is no lung sliding.
Okay, very good. So what I'd say is there is an element of lung sliding on this corner over here, but actually this area over here, there's no lung sliding. And what you can see is a barcode sign. So you have got a pneumothorax. Now, it's only seen in R1. And when I actually move to R2 and R3, as I move, I can actually see sliding and we evolve into a seashore slime. So actually, it's a very small anterior pneumothorax, and R3 and R4 actually have sliding with seashore sign completely. So it's an anterolateral kind of an image where I've got what is an A dash profile in R1. So this area over here is where we can't see good sliding. And this is the area where when I do M mode, sorry about that. So just over here, this is a classical barcode sign. This is the A profile. It's R1 anteriorly. There is sliding there, and I can see a lung point with a very small anterior pneumothorax. Now, would you like to give this baby surfactant?
What about the other sectors?
Yeah, very good. So when I look at R3 and R4, again, I see decent well aerated lung. When I hit R5, R6 and L5, L6, that's where I start getting what is an AB profile with a lot of lung spared region. But Dominantly, I'd say an element of a B profile, but no subpleural consolidations in any of these regions.
By this, now you don't need full surfactant.
Okay, so that's helpful. What do the others think? Would you give him surfactant?
No, يعني about this study ultrasound maybe with a normal, there is no need for surfactant for at this time.
Okay, that's great, Dr. Ashraf. What do the others think? I'm just curious. Any others? Any other viewpoints?
And back to clinical correlation, Alok,
Yeah.
Satish here. I mean, you
Yeah.
said although babies in about 35% oxygen with CO2 retention, I think the question we need to address is, I think if I remember correctly, I think there is significant work of breathing.
Yep.
And the baby is already on PEEP of 7 with significant work of breathing. Yes,
Excellent.
we have detected small anterior pneumothorax in R1. Rest of the zones, it doesn't classically fulfill the criteria for significant surfactant deficiency based on the information so far.
Yep. The question is, management-wise, what would you like to do? Is there anything that you think might help?
We can put it in NIV. يعني we'll translate from the CPAP to NIV trial for NIV.
Okay, I mean, my worry about using an IPPV is, again, you'd be using a lot of pressure. Potentially, you'd be going up. I mean, what about just using some Optiflow? So basically, in this situation, what we decided to do was go on to Optiflow and give this baby another hour or so and see what happens. Does the pneumothorax get worse or does it get clinically better? Now, actually, the baby clinically improved, and I'm just showing you the lung ultrasound after a few hours. So what do we think? It's the image at the bottom, R1 and R2.
Now sliding well.
Yeah. So you can see comet tails there. That's in R1
Yeah.
all the way through.
Yeah.
Can you see the sliding now?
Yes. Yes.
This is R2. I do have a little bit of what I would say is mirror image sign. So a kind of a truck sign, but actually M mode in all these areas showed a seashore sign. Now, just quality of the image. What is happening is my depth is very high and I'm using a high frequency because I'm really keen to focus on the pleura in this zone over here. And because I'm keen to focus on the pleura, I'm losing depth. So the way I would improve my image is I might drop the frequency just to see deeper images. But really here, what I do want to do is I want to focus entirely on this region. I want to see pleural sliding, and I really want to make sure there are no subpleural consolidations. Again, in all areas. Can we see any subpleural consolidations?
No.
Okay. So, I mean, this baby gradually got better. And from our perspective, about 900 grams, technically got away without a tube for a few days and then had a secondary deterioration with some sepsis. But it's a good example of what I would say is the importance of clinical correlation alongside doing lung ultrasound. And really, the X-ray appearance also showed very small right anterior pneumothorax with what looked like very, very, I would say, spared lungs. You kind of stressed IUGR baby. Now, we could have given this baby surfactant on clinical grounds alone because he had a high FiO2 requirement right from delivery suite. Now, the risk in this situation, if you have a right pneumothorax, is lung compliance on a high PEEP. You give surfactant, you reduce the lung compliance, more pressure to that right lung, and there's a risk we could have actually made the pneumothorax worse. So again, I'm just giving you a flavor of how important lung ultrasound and how helpful it can be in these circumstances. Now you can get an X-ray, and that would help you just as much, to kind of make the diagnosis as well. So you can make a diagnosis with both, but for units who might have radiology coming off-site, taking time, it might take a long time before you can actually treat this baby with the best treatment that you think is possible. Just with that discussion, what I'd like to do is give you a little bit of a flavor of how we've come about using lung ultrasound scores and a little bit about the clinical kind of uh, progress we've made with management of neonatal respiratory distress syndrome and why and how lung ultrasound has come in. So for that, just a little bit of background. So we know that, prior to 2013, A lot of us, I mean, I certainly know that in the UK in 2009, I think we were intubating and ventilating, giving surfactant to anything below 30 weeks of gestation. I would say a lot of babies between 30 and 32 weeks were also getting tubes, depending on their clinical presentation. But I think work done through the COIN and the support trial established that CPAP, is a really good non-invasive modality that prevents exposure to mechanical ventilation. And this, after 2013, in the European guidelines, became first-line therapy. What was recognized, however, that there's an element of CPAP failure. And really the question is how we recognize those babies so that we can give them surfactant. Because if this surfactant is given within the first 2 or 3 hours of life, actually clinical efficacy is good. But more importantly, there is evidence from at least one Cochrane trial which basically shows that you can reduce both mortality as well as bronchopulmonary dysplasia the earlier you use surfactant, especially if you use it within the first 3 hours and within the first 12 hours. After that, there is obviously a risk of having higher morbidity. Now, having said that, what we know from our perspective is that there's a significant proportion of babies who will start CPAP and will fail. So again, just to kind of give you a little bit of a flavor, the support trial basically provided non-invasive CPAP therapy to a group of babies compared to infants who had surfactant therapy, which was their kind of protocol at the time. Now, what they actually were able to demonstrate was that for the babies who had CPAP, they were less frequently required intubation. They had uh, less need for postnatal corticosteroids and actually fewer mechanical ventilation days. But there's a very stark figure. So 70% of babies who were actually randomized to go into the CPAP group were eventually intubated either in delivery suite or in the NICU. And a significant number of these babies were intubated within 24 hours. Now, that is a staggering number of babies, which kind of means that whilst we want to support babies, extremely preterm babies with CPAP and non-invasive ventilation in the form of, I mean, some units I know are now using Optiflow in delivery suite. I know that units in Oxford use a lot of Optiflow as well. But clearly, when these babies fail, they'll need intubation surfactant. The later we leave it, the higher the risk of morbidity. Now, the question from our perspective is, what do we use as a guide? But before that, really, is there high quality evidence that giving early surfactant uh, actually results in better outcomes? Well, there's at least one Cochrane review published in 2012 which demonstrates this. And certainly a lot of work that's been done after the support trial, which basically shows that if you give surfactant to babies within a plausible interval of 2 to 3 hours, then those babies tend to do better in terms of having fewer days on the ventilator, but more importantly, a lower risk of having BPD at 28 days. Now, these early studies were very important in establishing CPAP as the first line, but a lot of them then were extrapolated to try and identify babies who would need intubation and surfactant. And the best kind of way espoused through these observational studies and randomized control studies was the use of FiO2. That kind of was extrapolated so that in 2018, the European guidelines for respiratory distress kind of came up with a figure of saying that if you're under 28 weeks and your FiO2 is more than 30%, then you should have a tube and surfactant. But if you are kind of over 28 weeks and your FiO2 is over 40%, that group of babies can kind of have surfactant only if the FiO2 crosses 40%. Now, that is kind of plucked out of air. And it really comes back from the work done in the COIN trial, which showed that if you left babies on CPAP pressures that they use between 5 and 7, then there was a slightly higher risk of having a pneumothorax if you let the FiO2 rise beyond 40% in a group of babies. The incidence was as high as 10%. Now, the problem with that is really it results in the treatment of babies late. And this is what we're going to talk about, in that the current existing parameters for surfactant treatment, in particular, if you just use FiO2, might mean that a baby may actually miss the kind of 3-hour window for treatment with surfactant. And this has been well demonstrated in a lot of lung ultrasound studies that I'll subsequently talk about. Now, for me, one other very big problem with just using FiO2 alone, so just saying that, look, if you're less than 28 weeks and you're over an FiO2 of 30%, I'm going to give you a surfactant, uh, is it doesn't individualize to the baby. Now, for a baby who doesn't have steroids, who is a boy, where there is an element of perinatal compromise, it may well be that that baby actually needs to have surfactant at an FiO2 that is actually less. Alternatively, if you are quite stressed in an IUGR baby who has an element of sepsis, you might actually have a better lung condition at birth. Now, the question from our perspective is, are those babies that are going to honeymoon and deteriorate later on? But the evidence wouldn't support giving them surfactant empirically. So again, just saying that you have an FiO2 of 30% without taking these factors into account means that you're going to treat all babies in one way, which I don't think is appropriate. What is also recognized is that we might have babies who have fluid, and in particular, if you look at babies between 28 and 32 weeks of gestation who are steroided, the incidence of surfactant deficiency drops from 80% below 28 weeks to about 50%. Now, the presence of fluid in those babies, if they've been delivered by an elective cesarean and the mother's not in labor, the presence of elevated pulmonary pressures may all account for a high FiO2, which might mean that these babies then get treated unnecessarily with surfactant because we've kind of got these arbitrary thresholds. I want to kind of emphasize that there are no randomized controlled trials of looking at what FiO2 we should have used. No randomized controlled trials of babies between 21 and 30%, 30 and 40%, or more than 40%. All this kind of demonstration of morbidity comes from observational studies. So really, again, I worry a little bit about just using FiO2 in isolation. For me, really, the key question is then, if we're not going to use FiO2 in isolation, are there other parameters that we can kind of think of? And really, if you look at clinical parameters, then clinical parameters are very subjective. You might have a baby who's come in who has significant work of breathing. But the question is, I'm just going to give you an example. When I was in Southampton, we would start with delivery room CPAP for most babies over 25 weeks of gestation, if they were decent sized. But we would provide them mask-based PEEP in the delivery suite. We would then have one interface change when they're moved to the transport incubator. We would then have a second interface change once the transport incubator came to the neonatal unit, which kind of meant loss of PEEP, loss of FRC, at least twice during their journey. Really handling lines, all of those things often meant that the effective delivery of PEEP to keep them well recruited, the effective delivery of CPAP, was a real struggle. And the more preterm the baby, again, prong sizes, having the ability to be able to keep uninterrupted seal was a real challenge in the first few hours. Not unexpectedly, we had a very high CPAP failure rate where we kind of, I'd say under 28 weeks, a lot of babies were getting intubated and receiving surfactant. But actually, there are units who still continue prophylactic intubation because of the distance between the birth of the baby. The ability to provide effective CPAP is not as good in delivery suite because of these interface changes, but more importantly, because of the distance for which we have to move these babies. Now, naturally, those are babies who might come, and you might make your assessment on the neonatal unit with them having had ineffective recruitment because we've not been able to keep the PEEP. And in those situations, what you're really interpreting in terms of clinical signs and symptoms may not be RDS and surfactant immaturity. It might be just your inability to give PEEP effectively. So unless you're taking all these factors into consideration, really, again, clinical parameters would not necessarily always be an accurate marker in isolation of the need for surfactant in these babies. I think for us, why is why is PEEP important? It's because we want to avoid intubation. We want to really prevent mechanical ventilation of these babies. And there are different ways in which we've kind of evolved into providing these when we have PEEP failure on the delivery suite. A real question for us is really how we identify the babies who really need it. And that's where I would say again that certainly the existing parameters of FiO2 alone, FiO2 with radiology, clinical parameters, scores like the Downs and the Silverman-Anderson scores are extremely poor in being able to tell us which babies read surfactant versus which don't. Of all of these, when you look at the analysis through observational studies, FiO2 is quoted as being the most common. And that then brings me to, well, you have a more objective method to actually now determine whether a baby has surfactant deficiency, which is lung ultrasound. Now, as I've spoken in the last session, compared to just observational studies for FiO2, I mean, I'm counting 1, 2, 3, 4, 5, 6, 7, of which at least 5 studies are randomized controlled trials. We have all of this put into a meta-analysis by Raimondi. I mean, this is good, I would say, grade A evidence that you can use lung ultrasound not just for the diagnosis of respiratory distress syndrome, but also for the diagnosis of consolidation. Being a very specific marker, if it's visible in the subpleural region, of being able to differentiate respiratory distress syndrome from transient tachypnea, other conditions, of being able to diagnose a pneumothorax if the baby's surfactant deficient, of being able to diagnose comorbid conditions, pneumonia if you have a fractal sign, or dynamic air bronchograms. So not only can you diagnose RDS, you can diagnose comorbidity, but more importantly, what these studies also demonstrate is that by using a lung ultrasound score, you can actually determine when the first dose of surfactant should be given. And as I will describe to you, this can be done much more quickly than just FiO2 and clinical parameters alone. Before I move on, are there any questions? So I'm just curious, just everybody, is everybody using CPAP, or are you prophylactically intubating babies and giving them surfactant delivery suite? So I'm specifically talking about babies under 28 weeks of gestation. I'm just curious to know what your practice is.
If the baby vigorous, if he good work of breathing, even the stress, I will the CPAP first.
So 23, 22 weekers? You happy?
23, I hear 28.
So I'm just, if I give you a range of 22 to 28 weeks,
يعني below 24 week I will intubate for at least for 5 days till the storm of APH pass away.
okay. Okay. What about others?
Satish here, Alok.
Yeah, yeah.
I mean, we are moving more and more away from prophylactic intubation surfactant. Obviously, 22 to 24 weekers, I think we are still invariably tubing. But 25 weeks upwards, if baby has a good respiratory drive, we're aiming to manage on PEEP at least until the admission to the unit, and then we'll make an assessment taking into consideration all the other clinical parameters before going down the route of surfactant. So it's kind of individualized, but there's no formal agreement per se, like let's not tube or let's tube one or the other way.
Sure, that's really helpful. That's so Dr. Ashraf and Satish have shared that. I'm just curious, what about Praveen? What are you guys doing in Brighton?
So I think quite similar to Satish. 22, 23 weekers likely to get intubated. 24 weekers, I have brought some of them on CPAP. 25, 26, more and more chance CPAP. And even 26, 27 weekers just coming on high flow. 26, 27, 28 weekers likely on high flow.
Lovely. So I think all of us will agree that there's a spectrum, even below 28 weeks. Shruti's just said that 24 to 26 weeks generally get ventilated and given surfactant. More than 26 weeks. So I'd say that really, what is really important in situations like this is the individualized management. And I think that applies to lung ultrasound as well. But just kind of looking at lung ultrasound and its accuracy in predicting surfactant replacement, a few questions arise. So, how should we use a lung ultrasound protocol to be able to implement the effective diagnosis and management of respiratory distress syndrome for babies where we practice in different units and where we have different gestational cutoffs? Our level twos will tend to keep babies over 26 weeks, so the 27 weekers and above. Level threes will kind of have a spectrum of babies between 22 and up to 37 weeks. And then really, I would say that, if you look at level one babies, who's to say that they may not get, a near-term baby or a term baby who, for reasons of diabetes in the mother, may actually have respiratory distress syndrome. So in those situations, the question is, how do you implement a lung ultrasound protocol and a lung scoring protocol to be able to satisfy this kind of spectrum? Now, I'm just gonna, in this particular graph, talk about a few of the studies and the cutoff levels used, because I think it's really, really important. And what I'd say is that the Bratt did the first study of lung ultrasound scores using the anterolateral kind of method. And really what they found is that if you took a lung ultrasound score of, I would say, more than 4, which is quite low, you really had a sensitivity of nearly 100%. Now that's great, but really it will result in a lot of babies being treated. Now this study basically looked at babies predominantly, I'd say 25 to 37 weeks of gestation. And really what they found was that for babies below 34 weeks, the lung ultrasound scoring was fairly accurate, sensitive, and decently specific in trying to kind of differentiate RDS from the other conditions. But actually, over 34 weeks, it wasn't so good. The sensitivity and the specificity dropped. The problem with Bratt's work was the lack of sufficient number of preterm babies, in particular babies under 30 weeks of gestation. There was a very small number. So DiMartino, working along with Nadia, so both these studies basically done by Nadia Yusuf in Paris, was able to use kind of a cutoff of dividing babies to less than 30 and more than 30 weeks. And really, they came to a kind of a conclusion that, with a lung ultrasound cutoff of more than 6, the sensitivity was 0.9, specificity 0.8, again, for the diagnosis of RDS. And really, these two studies established really good evidence that you can diagnose respiratory distress syndrome, but you can actually use lung ultrasound scoring to kind of determine when to give the first dose of surfactant. This was followed by further work by Gregorio Hernandez, basically again using, I would say, anterior and posterior zones, and then Raimondi's work in 2021. Now, these were all single center. Raimondi's work is very important because it was a multi-center trial. And really, they did the meta-analysis, which came to the conclusion that when you look at early studies, if you're using Bratt's method or anterolateral scoring in a standardized way using a scoring system of 0 to 3, then really a score of more than 8 has the best sensitivity and specificity for the administration of the first dose of surfactant if you suspect a baby has RDS clinically. So these studies really are very important. Now the question is, with all this work, so I'm just giving you a flavor here. We have no randomized control trials which actually correlate FiO2 alone, FiO2 with clinical status, FiO2 with chest X-ray, in telling us really when we should be giving a baby surfactant after birth. We have all this work over here, but what do the national bodies say? Well, the European Consensus Guidelines from 2023 actually endorsed lung ultrasound along with FiO2 as a method for us trying to diagnose RDS, its severity, and talk about surfactant administration. Interestingly, the American group, the American Academy of Pediatrics, did a very similar kind of a review, so kind of a Delphi consensus approach to trying to review the existing literature, and came to the conclusion that we're not quite there. I found that very interesting. Now, really, what the AAP or that study espouses is that really what we should be looking at is the baby clinically, as well as doing the FiO2 requirements. And really, if your FiO2 is more than 0.3 at any stage, in particular early on within the first 2 hours of life, then really what we should be doing is giving the baby surfactant. But if after 2 hours, we if the baby's not as symptomatic, unless the FiO2 rises above 0.4, we should technically wait. We might wait a little bit longer to give surfactant. Now, really, in terms of our approach, lung ultrasound is incredibly helpful because it's very objective. I mean, there's no doubt that this is well aerated lung, and there's absolutely no doubt that in the right clinical context, this is pleura that's blurred. There are, with the eye of faith, subpleural consolidations that are visible, and you've got a B profile. So objectively, the diagnosis of RDS can be made using a lung ultrasound more effectively. The problem with just using FiO2 in this particular situation is that what if the baby has a pneumothorax? What if this baby has a lot of fluid because he's an elective cesarean in the first 2 hours? What if this baby has elevated pulmonary pressures because he's perinatally compromised and he's been born in a setting where he's got an element of perinatal stress? Now, all of these factors are going to contribute to high FiO2 as well, not just surfactant deficiency alone. And it might mean that if you use FiO2, you're just going to treat I would say a lot of other conditions. Now, the reason I mentioned this again is because if you look at babies between 28 and 34 weeks of gestation, there will be a proportion of these babies who are surfactant deficient. And it's important that we treat these babies early as well to reduce morbidity and mortality. Now, the question from our perspective is, well, we've talked about lung ultrasound scores, but how do you classify severity? Really, what is severe respiratory distress syndrome? And a lot of people would argue that a chest x-ray will be able to tell you what severity is, because if you have a complete whiteout on both sides on a chest x-ray, which looks like you can't see the heart in a baby who is clinically symptomatic, well, that's severe. And the problem with lung ultrasound is, while it gives you a pattern that will help you confirm a diagnosis of RDS, it doesn't talk to you about the severity. Well, now we have a classification that's been published, not just by Dr. Lewis. This is basically work that's been done by Douglas Blank, which basically looks at the severity of the progression of lung ultrasound scores. And again, what he talks about is well aerated lung, a score of 1 where you have more than 3 B lines per intercostal space, basically what looks like whiteout or alveolar interstitial edema in every space. And then you start seeing basically what is an element of atelectasis. And then you see atelectasis, which is severe with significant consolidations. So you can actually classify the severity of lung disease and respiratory distress syndrome. The question is, how do we quantify that in relation to the clinical course of the baby? And that comes from this work, which I shared with you this morning, that's been published by Professor Jing Liu. And what he talks about is that if you have babies who technically do not have much work of breathing, and on the lung ultrasounds, you can see an element of ground glass opacities. And I'm going to show you some images which confirm that, with mild consolidation that doesn't quite look like a snowflake sign, then that really is mild RDS, or what is defined as grade 1 respiratory distress syndrome. On the other hand, if you start seeing extensive consolidation that resembles a snowflake sign, which involves kind of some of the lung regions. So they've defined it as saying that not all 12 regions are involved, that you can involve up to 11 regions. Again, clinical correlation is quite key. Then really they call that grade 2 RDS. On the other hand, if you then start seeing a snowflake sign or atelectasis in all 12 regions, and or you start seeing significant clinical complications with work of breathing as espoused with like pulmonary hemorrhage, or if you have a pneumothorax or PPHN, or start seeing large areas of atelectasis, then this becomes severe or grade 3 RDS. And really, this is quite important, because if you start seeing either of these two kind of situations, grade 2 or grade 3, in a baby where there are clinical symptoms, then really the question from your perspective is, do you really want to wait for an FiO2 to reach 30% if you're doing an ultrasound in the first 2 hours, or you may really want to give surfactant early? And that might, from our perspective, have a plausible kind of allow a plausible improvement in this baby, which then means this individual baby has a better clinical course. Now, the question is how we make that diagnosis on ultrasound. And this is a really good example. So I want you to look at the right-hand side over here. Now, ground glass opacification, as described on lung ultrasound, characteristically doesn't quite give you the snowflake appearance. So you'll have pleura that's thick, might appear a little bit blurred. You will have these subpleural consolidations, but this is the classical snowflake appearance that you see over here. And you don't quite have that when you have a ground glass appearance. But what is more important with the ground glass appearance is that the compact B lines that you see, they actually fade as you reach the bottom of the screen. So this really, from our perspective, in Jingliu's experience, falls into a category of grade 1 RDS. And most of these babies will not show significant areas of consolidation. They will not, from his perspective, be clinically very symptomatic. On the other hand, you can see how, again, we're now progressing into a region where we don't have quite a snowflake appearance, but we have quite significant interstitial edema. Again, really, this, from his perspective, is really what he would classify as mild RDS or grade 1 RDS. But once you start seeing a classical snowflake sign, really, that's where he would say that this is really grade 2 RDS. Now, just remember, you might be looking at this baby in the anterior regions and you might see this appearance. But in the posterior regions, if you see this appearance, we always regard the posterior regions as being important when you do extended lung ultrasound scores. But you take the region that's more severe and then grade your RDS, taking into context clinical correlation. So this is just an example of how you can look and assess the severity of lung ultrasound without scoring to kind of determine whether a baby has mild, moderate, or severe RDS. Now, the question from our perspective is, well, we use this. We use these clinical criteria as well, along with the lung ultrasound. And if you implement it in practice, are there benefits? Is there any work that's been done that actually shows that this actually works in clinical practice? And that work has been done by our French colleagues using basically a quality improvement project that involved what is echocardiographic guided surfactant therapy, or the ESTER protocol. And this is, I would say, what has laid the foundation for the use of surfactant early on in treatment of respiratory distress syndrome for units that are predominantly providing non-invasive respiratory support after birth. So if you're a unit whose ethos is, well, I'm going to tube everything under 25 or 24 weeks because really my delivery suite is a mile from where my baby is going to be. I can't effectively provide delivery room CPAP. Really, this would not be applicable in that setting. And that's where I would say that it's really important that you understand that the most of the protocols that now use lung ultrasound are really trying to differentiate babies on non-invasive respiratory support who meet the criteria for surfactant deficiency so that we can treat them early to prevent further morbidity. Before I go on, any questions? So any questions about this particular aspect of severity or any comments? I'm just keen to know from the group.
Yes, Eric, please. The
Yeah,
snowflake science, it is some sort of multiple sub or micro
consolidation.
consolidation matrices.
Yeah, that's true. Yep.
अस्सलाम वालेकुम आरिफ, क्या हाल है? ठीक ठाक। अच्छा, ये एफसी ग्रुप पे जो है ना एडमिन आप हैं, तो इसको वहां से आप जो है ना खत्म करेंगे ताकि
So yeah, just you're absolutely right. They are micro consolidations. And like a very good example from our perspective is this is a classical snowflake sign. This is atelectasis with a snowflake sign. So really, the snowflake sign is severe because you've got significant lung atelectasis. You have no pleural line established over here. But when you look at this particular area, this is white lung. Now, if you use this alone as a marker of trying to differentiate whether a baby has TTN or RDS, then because you don't see subpleural consolidations, you might not be able to differentiate both of them. So the presence of consolidation is very important. But in terms of classifying severity, again, a simple example that I'll give you is that this is basically a snowflake sign on the left side. On the right side, you can't quite see a snowflake sign. So this is mild RDS at this particular point. If this baby does not have significant work of breathing, really what you can see is the right side having regular pleura with what is a dominant B profile, uh, the R3 and R4 gradually evolving into what is a very mild snowflake sign. And then you see more of a snowflake sign towards the back. And this is clinical progress seen in a baby with RDS from front to back who's being managed on CPAP while he's supine. So I would look at these images and I would clinically correlate, because if this baby is in 23% and you use Bratt's score, really anterolateral scoring, then you'd really give this baby a 2 for here, possibly a 3 for here, which would kind of, from our perspective, mean that if this is R1, R2, he gets 4 plus 3, 7, 14. So eventually this baby will need treatment. But the posterior regions are going to be bad because of atelectasis anyway. And that's where I would say that there are challenges with how we use lung ultrasound scores, and that clinical correlation is very, very, very important. Because if this baby does not have significant work of breathing, the real question I'm asking myself is, why is it that I'm getting this ultrasound appearance? And again, I would go back to the quality of the images I'm getting. So just to go back to the present, any other questions? So we've talked about severity. Now, what is the ESTER protocol? So the ESTER protocol basically allows us to manage babies on non-invasive respiratory support. That might be CPAP in your units in delivery suite. I think the majority of units, at least where I work in the UAE, would CPAP a certain proportion of babies. I think, we try for babies 26 weeks and above. I think a significant proportion of babies under that would start delivery room CPAP, fail, and probably get intubated and have surfactant. But in Paris, this work has been done in a level 3 unit in Paris at the Antoine Becler Hospital. And really, for them, they will CPAP all their babies. Now, this study basically had a significant proportion of babies over 24 weeks, including 24 weeks. And really, what they did was that when these babies came to the unit, they performed a lung ultrasound. Now, the study doesn't mention the exact timing of the lung ultrasound, but having spoken to Nadia and her group, the majority of lung ultrasounds were performed within 2 hours of age. And really, if the score was above 8, these babies were given surfactant therapy. Now, they do not use chest x-rays to diagnose RDS in their unit. What they were able to demonstrate through this is that really they were, for the babies who had lung ultrasounds that met a threshold and were treated, the duration of invasive mechanical ventilation was much shorter. The duration of oxygen therapy was not significantly different, but these babies had uh, a larger number of ventilation-free days. Again, the difference in BPD between the group of babies who had lung ultrasound versus those who were treated by FiO2 alone was not significantly different, but you must understand that this is a quality improvement project. It's not a randomized controlled trial and wasn't powered to look at those differences. What it did demonstrate is that a process of training in lung ultrasound, introducing this into practice through the implementation of the ESTER protocol. And what is the ESTER protocol? So the ESTER protocol says that for any baby between 24 and up to 35 weeks gestation, if they had respiratory distress, they would have delivery room PEEP. They would then be CPAP'd onto the neonatal unit. They'd have their golden hour management. They'd have caffeine. But more importantly, from our perspective, they would have an early lung ultrasound, preferably done about 90 minutes to 2 hours of age. And if that score was above 8, they would not wait for the FiO2 to increase. They would really, if the FiO2 was under 30, they would opt to treat those babies. When they started the ESTER protocol, if the FiO2 was above 30, then those babies, irrespective, went on and really got surfactant. And really, again, it's interesting to note that a significant number of babies had a shorter duration of surfactant therapy. But more importantly, what they also were able to demonstrate is that for those babies who had lung ultrasound within the first 3 hours of life, uh, they they a significant proportion of them had surfactant much earlier than they would have had if they had used FiO2 alone. So really, it's a good example of how they've used lung ultrasound in practice to actually support their kind of belief that actually you can successfully use lung ultrasound as opposed to FiO2 alone for the treatment of these babies. And that actually, if you use lung ultrasound, you might be treating a proportion of babies much earlier than if you used FiO2 alone, because it takes time for some of these babies to develop surfactant deficiency. And you can imagine that those babies, if they become and reach an FiO2 threshold of 40, if they're over 28 weeks of gestation at 18 hours of age, well, the surfactant is going to be less efficacious. The evidence is that they've missed out, and then they might spend a longer period of time being mechanically ventilated and having chronic lung disease. Now, that brings me to how do we as a group, while we're learning lung ultrasound, want to implement point of care ultrasound in our practice? So what is the current evidence based on all the work that's been done by these studies? And to summarize, I'm going to summarize some very small questions. So what protocol should I use? So if you're developing a protocol now that will incorporate lung ultrasound as an investigation in the management of RDS, the key question is, are you going to use lung ultrasound alone? Are you going to use it in conjunction with FiO2 and clinical signs and symptoms? Are you going to use it in conjunction with a chest X-ray? Well, that is something that you need to think of very carefully, and I will be providing you the protocol that we use, that we've developed for Southampton before I left. We decided that we would go with Brat's protocol, and the reason for that is its anterolateral approach. It's less handling for the extremely preterm babies. There is currently no evidence to say that the posterior regions being scanned gives any additional advantages, but more importantly, from our perspective, that there is more accuracy, a higher sensitivity or specificity, or that it will actually benefit us in giving the babies who need surfactant earlier. So there is currently no evidence that either Zemansky's protocol or the protocol that is used by Rodriguez-Fangel, which uses the posterior regions, are any better. The problem that you will have with trying to use those protocols is they use anterior and posterior, or anterior, lateral, and posterior. That's a lot of handling for the baby. For the posterior regions, you'll have to push the baby prone, leave him for a bit and do them. Now, the challenge with that is for extremely preterm babies, you'll have umbilical lines. That's not going to be easy to do. In my opinion, I would say that you can actually do the Bratz protocol. Now, some people will argue, well, what about if the baby is already prone? Well, you can do the Bratz protocol with the baby prone by using the posterior regions, upper and lower, and the lateral regions as you would have used the anterior region without moving the baby. And it is just as efficacious and applicable. So certainly for our protocol, we use this. Now, I know that for a fact, some people want to use the posterior region protocol, and the reason for that is there's an argument that you might see consolidations earlier in the posterior regions because these regions are less well recruited. The consolidations, the surfactant deficiency, naturally, if you're recruiting and using CPAP and a baby is getting worse, where respiratory distress syndrome is progressing, your surfactant inactivation might be worse in the posterior regions because you're better recruited with CPAP anteriorly. So there's an argument by some of our colleagues that they want to use posterior regions. If that is the case, which protocol would you use? Well, in my opinion, I'd use Rodriguez-Fangel. And the reason I would use that is because really they just, from our perspective, are easier to do. It's a large single center study. Again, they use the anterior, lateral, and the posterior regions. And really, again, it uses the same scoring system that is used by Brat. So it's a little bit easier for you to implement in terms of scoring out of 18. And the cutoff scores are, I would say, similar protocol. So what I would say is there's less likelihood to have confusion if you want to do it. More importantly, what I would say is that the question is, when should you do that lung ultrasound? So anybody have any views on when they should do a lung ultrasound? How early you should do it? I'm just curious. I'm curious to hear from the group. Is anybody doing lung ultrasound at the moment for surfactant
Yes,
replacement?
I guess I usually I do it after 1 hour to be settled, everything is going well on CPAP. I usually I
Okay.
do after 1 to 1.5 hours.
So why not at half an hour, Dr. Ashraf?
Maybe still gravity, is still coming from the OT. Don't disturb him.
Okay.
1 hour, I give servant 1 or 1.5 hours. It's okay for him if needed. Yeah.
Okay. That's a really fair point. So Dr. Ashraf is saying that there are other aspects of management that take priority, and I completely agree. If you look at most golden hour management, really, it's really important that you are maintaining good recruitment, that you have efficacious PEEP, that you're minimizing the interface changes, that you're getting your lines in, starting fluids, getting antibiotics where appropriate, that really are just as important as giving these babies surfactant. And I can't emphasize this enough. We don't want to get fixated here with surfactant alone, because a proportion of these babies will not need surfactant, but they do need sugar, they need dextrose, they need caffeine. Can I just say that if you're not giving these babies caffeine on time, that is really important. The ability to breathe, recruit their lungs is as, uh, is needs caffeine. And if you're not getting your caffeine in, because you're doing a lung ultrasound within half an hour, which is a lot of handling for the baby, you might actually be making things worse. So those are some of the reasons for not doing it within half an hour. I will share a paper with you by Douglas Blank tomorrow, which actually looked at lung ultrasound in delivery suite. So they did scans at 30 minutes. So, again, they have shown good correlation between having whiteout lung at that particular period and the need for surfactant later on. My personal view is I think there are other priorities. Surfactant in my mind is never an emergency, unless you have very severe RDS and can't oxygenate. I would say that just be careful of trying to do an ultrasound at 30 minutes when you're resuscitating a baby. Keeping him warm is just as important. And if you have a hypothermic baby, you're taking a plastic bag off to try and do an ultrasound at 30 minutes in a 24, 25 weeker. I think you might be doing this baby a huge disservice. Any other thoughts? So, any other thoughts? Anybody else?
I think it's the same as you said. The logistics make it quite difficult to, assess the baby before the first couple of hours. Also, I think in the first couple of hours, you are hoping that they'll get onto some CPAP or high flow and settle down. And only if that has not happened, then you sort of start thinking, okay, do we need to investigate this, whether the baby needs surfactant?
That's
So.
beautiful. So, can I just say that if you have fluid in the first half an hour and it gives you an AIS pattern and that gives you a B profile, really, and you end up treating that baby with surfactant, you will be treating a proportion of babies, especially between 28 and 32 weeks of gestation, steroided girls, good sized, lung spared regions. You might end up treating them unnecessarily if you do your scan too early, because you'll get a high lung ultrasound score because of the presence of interstitial edema. And that's why I would say that really what you have to do is give this baby a chance with good recruitment from whatever non-invasive strategy that you want to use, so that you can do a lung ultrasound that gives you an educated assessment that this is really surfactant deficiency as opposed to being a lot of other conditions. That being said, there are some babies who will need surfactant on clinical grounds, work of breathing in delivery suite, the lack of ability to saturate. We know that extremely preterm babies can have very severe surfactant deficiency right at the start. So I'm not saying that you do a lung ultrasound in all those babies. You might have to decide on clinical grounds that those babies actually have to have surfactant even before you can do a lung ultrasound. So clinical correlation, clinical assessment is absolutely crucial. Now, one of the big questions that really needs research is, after I do a lung ultrasound, and if I get a lung ultrasound score of more than 8, and I can demonstrate subpleural consolidations, and I'm confident that this baby really is surfactant deficient and needs to have surfactant treatment, what is it that I'm going to do? Well, the question is, do I intubate, give surfactant, ventilate? Do I insure this baby? Do I do LISA? Do I do insure recruit? And really, does lung ultrasound give me any information that would help me differentiate what approach I'm going to take in terms of surfactant replacement? And at the moment, we don't have any work that actually helps us or gives us any answers to these questions. So my advice would be that if you're incorporating lung ultrasound in your protocol and you plan to do a scan between 60 minutes and 2 hours of age for babies who are on whatever non-invasive protocol you follow, then you follow your unit-based protocol for how you manage them. My own approach is really to individualize. So if I have an unsteroided boy who is sick, who might have an element of, I would say, sepsis, well, these are babies who I worry they may well need a second dose within 12 hours. Now, the question is, am I going to LISA him once now and then realize that I'm going to have to LISA him again? We know that the sensitivity and the specificity of using lung ultrasound when you want to give the second dose is less accurate as compared to when you want to give the first dose. So again, individualizing for that particular baby, I might say, well, let's tube him, keep him on the ventilator. Let's see what his clinical progress is like. We can extubate him early if he responds well, but really there's the option of giving him the second dose. Now, I know for a fact that there are units who still practice Insure. I don't know if all the French units uh, tend to prefer Insure as compared to LISA. Now, naturally, there's a worry that you're going to give mechanical ventilation to the baby. You're going to have to give IPPV. That might be damaging. But I would say that a lot of units, I'd say Germany, virtually the whole country, I'd say a lot of units in the UK are starting to implement less invasive surfactant therapy. Now, I just want to emphasize again that there is no difference in cutoff scores at this particular point based on the study that has been done by Bratt and DiMartino to say that we'd be using a different score that a kind of that you'd use Insure or Lisa based on that. There's nothing that actually says that. Really, what you have to do is decide what score you're going to use. And if you're using Bratt's method, a score of more than 8 gives you a really good sensitivity and specificity, provided you clinically correlate. Really, how you manage the baby should then follow your unit-based protocol. Some units will intubate, extubate. Some units will practice Lisa. Some units, really from our perspective, still will opt to intubate, give the baby surfactant, make sure the baby's stable, is improving, doesn't need a second dose, and go for early extubation. There's a large study that is being performed by a huge group of European colleagues at this particular point, which is going to look at this question because it's recruiting babies really that have all of these 4 different approaches because it's a multi-center trial. And it may be that they actually give us more information about what the right approach is when you use lung ultrasound and you try to treat these babies. What about a repeat dose of surfactant? Well, just again, I'd like to emphasize there's only one study that actually looked at the sensitivity and the specificity when you're trying to diagnose surfactant deficiency after you've received the first dose. And really what they found is that when you're looking at lung ultrasound scores, a score of more than 10, and these were lung ultrasounds that were done at about 12 hours of age, had the best sensitivity and specificity for the second dose of surfactant. But really, it was lower as compared to a score of more than 8 for the first dose. And again, what I would like to emphasize is that most of these studies did not have extremely preterm babies under 24 weeks of gestation. So just be very cautious if you decide to use a repeat lung ultrasound, because my experience is that often when you give these babies surfactant and they don't respond, that you do a lung ultrasound and really the question that you have to ask is why they're not responding as opposed to what the lung ultrasound images actually show. Because if you've given surfactant, the lungs are full of fluid, you will get a B profile, you will get alveolar interstitial syndrome. And really the question that you will then convince yourself that this is really bad RDS and they need the second dose of surfactant. They may well have a pneumothorax that might actually be causing the oxygen requirement. They might have pulmonary hypertension as well. So really, it's really important that if you're doing a repeat scan, that you're really trying to exclude any of the complications that might occur? Is this surfactant in the endotracheal tube that's caused the blockage? And that's why you have such severe whiteout and atelectasis in the lungs. All of these things are really important. Is the tube down the right main bronchus? Is it that the right lung has received more surfactant and that the left lung still looks a whiteout? So the question from your perspective is, it's not just about the lung ultrasound score and its kind of ability to predict retreatment. It's really when you do that lung ultrasound, what you're trying to diagnose. And for me, what I would say is, one of your questions will be, well, when do you do your lung ultrasound after you give a baby the first dose of surfactant? Well, if this baby improves and goes into air and is clinically stable, I don't. I really manage this baby clinically. And the question that I would always ask is, can I take this baby off the ventilator? If I'm keeping him on the ventilator, what am I doing to optimize his condition to actually get him off the ventilator? And I do that every day until we get the baby off the ventilator. But a repeat lung ultrasound if the baby's improved clinically is really not necessary. The reason I would do a lung ultrasound is if my baby's not improved, i.e., he still has work of breathing. Clinically, I'll go back, I'll examine him. The question from my perspective is, airway, breathing, circulation. Well, is the tube in the right place? It's not down the right main bronchus. Where is it at the lips? Do we have equal air entry? Do we have evidence of a pneumothorax clinically? Is this a baby that's still recessing quite severely? Or then I would do my lung ultrasound. And in the lung ultrasound, I'm following an enhanced protocol. I would do all my regions. The question is it surfactant? Does this baby need recruitment? Do we need higher pressures? Now, if I have features that still show that I have severe surfactant deficiency, there's no evidence of a pneumothorax. I have scope, that shows that actually I don't have massive atelectasis to recruit the lung. Then I might repeat a second dose of surfactant if that is the case, but it's clinical correlation. On the other hand, if I see a classical A profile, well-recruited lung after my first dose of surfactant, uh, uh, no evidence of a pneumothorax, and a completely aerated R1, R2, R3, R4, R5, R6, and the same on the left side. The question I'm asking myself is, does this baby have pulmonary hypertension? Does he need to have an echo? So a lung ultrasound, and when you do it, is really clinically your decision. And experience says that you should do it if you think your baby's not improving, very similar to how you would reassess your baby clinically. The last thing that I want to kind of talk about is that uh, our lung ultrasound score is good for the diagnosis of management in RDS in near-term and term neonates. Well, if you remember Brad's paper, it showed that the sensitivity and specificity for lung ultrasound in the diagnosis of babies who were more than 34 weeks was not as good as if they were less than 34 weeks. That being said, if these babies have extensive subpleural consolidation, classical B profiles, as opposed to having a relatively clear demarcated pleural line that might just be a little bit thick with AIS and double lung points, then that would favor a diagnosis of RDS. So it doesn't mean that you can't make a diagnosis of RDS. It just means that actually your lung ultrasound scores per se might be less accurate. And the reason for that is we all know that there's a significant overlap between respiratory distress syndrome, meconium aspiration, sepsis. Who's to say that you might not find consolidation in these conditions as well? I would say subpleural consolidations are quite a specific feature of respiratory distress syndrome. So, if that's something that you can see, no evidence of a fractal sign, no evidence of a pleural irregularity, the CRP is normal, and this is a baby in 50-60% oxygen with kind of whiteout appearance in all areas, then, RDS is a very plausible diagnosis to entertain even in the term baby. The one thing that I do want to emphasize is that for babies under 25 weeks of gestation, most contemporary studies of lung ultrasound did not actually include babies under 24 weeks of gestation, so 23, 22 weekers. And that's where, again, I'd just be a little bit cautious in trying to say that you can extrapolate all of this to those babies. I think that's where I would say your clinical correlation, again, is very important. I have seen well aerated lungs in a baby at 22 weeks of gestation after your first dose of surfactant with a double lung point, with pleura that is well established, with no evidence of atelectasis. And that baby was in about 30-35% FiO2. Now, again, the question I'm really asking myself is, I've treated the RDS, what else is wrong with the baby? And really, when we did an echo, the duct was shunting uh, predominantly right to left with a significant TR gradient. There was pulmonary hypertension over there. But because we're in 60%, really the question is just giving this baby more time than actually rushing in with another dose of surfactant. So that, in summary, is really the approach that you need to think of in terms of your implementation of the use of lung ultrasound in babies with neonatal respiratory distress. If I summarize, over the last 10 days, we have covered how you make a diagnosis of neonatal respiratory distress, how you would use lung ultrasound in that process, how you would use lung ultrasound scoring in that process. And really, the question now is, for those of you who are not using it, how you would implement it as a protocol in the context of what you're doing in your units. In my unit, most babies under 26 weeks will get intubated, ventilated, and have delivery room surfactant. I'm not sure that lung ultrasound gives me a huge benefit in those babies if they have clinically improved and are doing well. But if they're not improving, really, again, the question is, I'm going back clinically, lung ultrasound might help me make the diagnosis of a pneumothorax that might need to be treated. So I would think very carefully of how you want to implement it. Over the next week, I will be sharing with you 3 guidelines. One which basically allows you to implement lung ultrasound in your unit with the appropriate governance, a protocol which follows lung ultrasound implementation and scores in neonatal respiratory distress syndrome, and basically a flow chart which helps you differentiate morphologically on lung ultrasound the different lung ultrasound pathology. We have time for just 1 or 2 questions. I want to let you go. So any burning questions before we go?
About the second dose of Cervanta,
Yep.
I usually I compound lung ultrasound scoring with oxygen index or SOII if non-invasive and alveolar oxygen ratio. If it is less than 2, I will get Cervanta, even with welcome breathing clinically, even the score 9 or 8. If the score 10, if we will score well, will actually gradient well, will no welcome breathing, I can wait. No need to get Cervanta.
Yeah. It's a really tricky question to answer because every unit has a slightly different approach to how you manage these babies. Now, the real question I'm asking, if I have the appropriate interface, the appropriate skills with my nursing staff, with good gas exchange, and for a baby who's come down into an FiO2 that's air, who's caffeinated and has really good respiratory effort, is can I extubate that baby? Can I get him off the ventilator? Are there any other factors that are going to interfere with his ability to stay off the ventilator? And those are babies who really I would be taking off the ventilator where possible. On the other hand, if you are going to keep these babies intubated, ventilated because of those issues, the logistical issues, the issues around the appropriate care of these babies, because we need good nursing experience, then really I worry that using lung ultrasound in that context, might not necessarily, the scores might not necessarily reflect uh, accurately our ability to give another dose of surfactant, because you've given surfactant the first time around, you're repeating a lung ultrasound at 12 hours, but this baby is clinically much better. Now, if I get a score of more than 10 in a baby in air, the question from my perspective is if he has good gas exchange, why would I want to give him another dose of surfactant? That's where I would say your clinical correlation is key. I think, if
Yes.
your baby is in oxygen, is in 30%, and it gives you that score of more than 10, then yes, that baby needs surfactant. But I would really argue that if your baby is well and in air, and we see a lot of babies who honeymoon for a period, but who we don't extubate because of all these issues around how we manage and care for these babies, the experience of the team. And I just worry that there are units I know who empirically top them up with surfactant at 12 hours and, kind of don't extubate them. I think really what you should be trying to do is implementing practices in your unit that provide the training, the staffing, and really the quality improvement processes that enable these babies to extubate, if they are able to extubate, so that we can care for them in a way that really necessitates, precludes giving them another dose unnecessarily. I think my kind of take-home message for that second dose of surfactant is, I think you really need to clinically correlate. And the question that I would always ask is, does that baby need to be on the ventilator if they're completely well? I have seen babies who are completely well, who are clinically stable, where I've done lung ultrasounds, and really the scores have hit 10 quite easily. And again, the question then is, are you going to treat the ultrasound or are you going to treat the baby? So I
The
would be,
baby.
yeah, absolutely. Uh, I know for a fact that some people will treat the ultrasound as well, and I think that's where I would say that maybe in a in a few years, we trained 35 people in our first batch. We're training another 35 of you who I know are all doing ultrasounds. I'd be really keen to ask you what conclusion you come to. What is your clinical guess, for how we should be managing those babies? Thank you very much, everybody. I'm really grateful. Have a good evening.
Thank you for this nice talk. Thank you.
Thanks a lot. Bye-bye.
Thanks, Alok.
Thank you very much. Thank you.
Thank you.
Have a good day.
Have a good day.
I just think the files of the system is just too large at the moment. It's worrying. I think this might not get recorded, the session.